Boom. Right. All right. Good morning, everyone. Welcome. My name is Rick Ellis with the Katy Area Chamber of Commerce. We are honored here today to have Dr. Arntz with Houston Methodist Hospital, and she'll be discussing, as it shows on the screen, prevention, diagnosis, and the treatment of breast cancer. So I am going to let Dr. Arntz take it away, and then we'll recap. If you have any questions, raise your hand, and we'll offer those questions up. So Dr. Arntz, it's up to you. Take it away.
All right. Well, thanks for having me. Good morning, everyone. This is a picture of my family, just to remind everyone that we all have multiple jobs, right? We have our career, but we're also wife and mom and daughter and sons, and we have lots of hats that we wear. Of note in this picture are my dad and many family members who aren't there due to cancer. And so I put this up just to remind us both why we're here, but also to remind us about those who we've lost so that we can help find cancer early, in particular today, breast cancer. And how do we find breast cancer? This is my great Halloween picture. This is how I wish we could find it. Just look into our crystal ball and see when we're going to get cancer, who gets cancer, and then how to treat it. Unfortunately, it's not really that easy. And so we have to know a little bit about what our risk factors are. And we know for breast cancer, the two biggest risk factors are aging and being a woman. And so those two things we really can't change. Age we hope to do, and women, that's just how we're born. There are some modifiable risk factors or some other things that you should know about to determine whether or not you're at an increased risk for breast cancer. That's whether or not you've had a biopsy of your breast before that has shown atypia. Sometimes the doctor just tells you yes or no, it was cancer or it wasn't cancer, but it's really those no's that are sometimes important. And so asking the questions or knowing whether or not your biopsy showed atypical cells can put you at increased risk of developing breast cancer in the future. Also knowing your family history, both on your mom's side and your dad's side, and whether or not there was breast cancer in women younger than 50, if anyone had bilateral breast cancers in both breasts, whether or not any men had breast cancer. You also should know your breast density. People should get mammograms starting at 40 and every year, and part of that report tells you your breast density. If you have dense breast tissue, you should be asking for an ultrasound as well. Now, these are things that your doctor should know and should be recommending, but it's always a great idea to help for you to know your health history so that you can be an advocate for your own health. Obesity post-menopausal is another risk factor. Gaining 15 pounds post-menopausal puts you at increased risk of breast cancer because you produce estrogen from your fat cells. If you had exposure to radiation, and this means that maybe you had you had cancer like lymphoma as a child and they treated that with radiation, or as a young adult, that would put you at increased risk of breast cancer. Early menstruation, late menopause, those years of having your menstrual cycle, the longer the number of years, the increased risk of breast cancer, as well as whether or not you're on hormone replacement. Although we don't think hormone replacement causes breast cancer, if you're on hormone replacement, you do need to make sure you're getting your mammograms every year. And what are some inherited risk factors that we got from our family? We've talked about some of these. Did anyone have breast cancer before the age of 50? Breast cancer in both breasts, male breast cancer, women who had ovarian cancer in the family. Ovarian cancer is a rare cancer, and anyone with ovarian cancer should have genetic testing because it is an increased hereditary risk. If we had multiple generations of breast cancer, so 3 generations or 3 women with breast cancer at any age, it doesn't have to be under 50, those are a high-risk family, or if you're of Ashkenazi Jewish descent. And what advances have we made in prevention? The biggest one, I think, is genetic testing. So being able to know if you have a genetic mutation, which puts you at an increased risk of breast cancer. We can test for many different cancers, including breast and ovarian, which we've mentioned, also pancreatic, colon cancer, uterine cancer, and melanoma. And the goal is to not only prevent the second cancer, if you happen to have had one of these cancers, prevent that second cancer that may be associated with the cancer that you had, but also to prevent cancer from being diagnosed in our families. These are the risk factors for, or the lifetime risk for people with identified gene mutation. You can see here, if you have an identified mutation that causes breast cancer, about 87% of people will develop that gene. Some colon cancers are almost 100% predictive as to whether or not you will get colon cancer. And some less known genes, but pancreatic cancer, gastric cancer, stomach cancer, or prostate cancer. Sometimes these are all, or these can all be associated with a genetic mutation. And when you have these mutations, it can cause about 20% of ovarian cancers are associated with these genes. And although we're talking about breast today, most women who develop breast cancer don't have a genetic mutation, but about 9% of the population who does get breast cancer does have a genetic mutation. And we have overlapping. So if you're in this teal area here with breast cancer, there are not only the BRCA genes, which I think most people have heard of, especially in the news, but some other mutations associated with breast and uterine cancer, breast and ovarian, and some overlap with colon cancer as well. And so you can't change your genes, but you can know about them so that you know what your risk is, your doctor knows what your risk is, and should we start screening earlier? This is what a family tree looks like when you meet with our genetic counselor and she goes through to see who's had cancer in your family. And testing for these genetic mutations is fairly easy. It's either a saliva swab, like you can see on this picture, or a blood draw. It takes a couple of weeks to get those tests back to tell us if you have a mutation, so then we can modify your risk or increase screening. This is often covered by insurance companies, but the good news now is that even if it's not covered by insurance, or some people don't want to file it on their health insurance, the cost now is about $250 out of pocket. Should you just want to pay cash to have this done, you pay directly to the company that does it. And then you know what your risks are. When I started doing this about 10 years ago, genetic testing was about $3,500. So it really wasn't a curiosity test that many people paid for. But that price has really come down and the science is better. We now test for 84 different genes when we do these genetic testing to see if any of those could increase your risk of cancer in the future. We have a genetic counselor here on campus at Houston Methodist West. Tiffany sees our patients not only to counsel them about what these genes may mean to you and your family, but also to help guide us in those risk reductions and what we can do to help increase screening. For mammogram, or if you have an inherited mutation, a genetic mutation that causes an increased risk for breast cancer, we can do a couple of things. We can increase screening, meaning mammograms and MRIs to help detect breast cancer early. We can do colonoscopies. The recommendation is to do screening colonoscopy every 10 years, but sometimes people need it every 5 years, every 3 years, and sometimes yearly, depending on which genetic mutation they have. And that allows us to both detect and often cure colon cancers or prevent colon cancers with just a colonoscopy. We can also reduce your risk for developing cancers with medication. Some low-dose cancer treatment medications like tamoxifen help prevent breast cancer by about 50%. And some birth control pills can actually decrease the risk of developing ovarian cancer because it stops the ovary from ovulating every month. And the most drastic option that we have to decrease the risk of developing cancer is surgical reduction, removing those organs that aren't necessary for life before they develop cancer. We can do that with breast prophylactic mastectomies, removing the breasts before they become cancerous. But we can also do it for your ovaries, your uterus, and your colon even, to remove that before you develop cancer. For the rest of us who don't have a genetic mutation and may not even have an increased risk for breast cancer, we should get yearly screening mammograms starting at 40. The guidelines have changed and are a little less strict. We don't talk about, or we don't recommend doing monthly self-breast exams. One, we forget. Secondly, you stop having your menstrual cycle, which is was the reminder that you should do your breast exam. When you get postmenopausal, you forget about that. And so the key now is just to get to know your body. I like to tell people the best way to get to know your breast is in the shower. As you're taking a shower, you feel your breast and you notice if any lumps, bumps change. Also, nipple position. I know this sounds weird, but look at yourself in the mirror before or after you get in the shower. And you just want to look for any changes in the breast, divots, changes in skin, anything like that that may be new. Most of us should have a risk assessment at about 30. This is usually done at the gynecologist's office, but this is to help identify who is high risk for developing breast cancer. High-risk populations also include Ashkenazi Jewish descent, as well as the African-American population. But in general, everyone should start screening mammograms at 40 and have those mammograms every year. And if a picture can save your life, it's not comfortable. No one wants to go have their mammogram, but it is truly a picture that takes you about 15, 20-minute appointments to detect these breast cancers early so that we can have many more options for treatment and can save your life. So you come in for your screening mammogram and then you get the dreaded call, the call back. And we understand that from that moment, you think that you have breast cancer until we prove that you haven't. And so at Houston Methodist West, we've actually decreased that time from your screening mammogram to coming back and getting additional tests is less than 3 days. So we start with more imaging. We do what's called a diagnostic mammogram, where we bring out these little pressure devices. And I know pressure is the doctor word for pain. But these little pressure devices that we put on the abnormal spot that we see in the breast on mammogram, and we push the other tissue out. If it is just dense breast tissue, then that breast tissue will flatten out. If it's still there, like in this picture, you can see this white dot in the middle of this dark breast tissue, then we move on to ultrasound. Ultrasound is done with a probe. You're lying there on the table. And then sometimes we had to move forward to additional tests like an MRI. MRI will give us the best resolution, meaning the most detail about any abnormalities that we see in the breast. MRIs are not always needed, and oftentimes we move on to biopsy. A biopsy is almost always done here in the United States with a needle. So you shouldn't have to go to the operating room for a biopsy. You can lie on one of these tables, depending on how we saw your abnormality that needs a biopsy. They numb the skin, and then they put in a needle so that we can take out some tissue to look at it under the microscope. This year, we will find about 280,000 new cases of invasive cancer. That means 1 in 8 of us without a significant family history will get breast cancer. And that's invasive cancer. There's about another 50,000 who will get in situ, which is stage 0 breast cancer. And although it doesn't sound like good news, but that means that only 1 in 35 women who get breast cancer will actually die of disease. And that's a 40% decrease in the last couple of decades. And that number is significantly improved compared to colon cancer, which is about 1 in 10, or pancreatic cancer, which is about 2 in 3 who will die of those cancers. So breast cancer, early detection, this is how we save lives. And right now there are 3.5 million women in the United States who have breast cancer as part of their medical history. So they are survivors and are out living their life after this detection and curing the disease. This graph here shows that early detection equals survival. And what you want to do is be up on this yellow, green, blue curve. So this is early detection, finding breast cancers almost always by mammogram. Most women had to have a cancer about an inch in size before they can feel it. And so we can find these tiny little cancers and cure them if we get our mammograms. And what happens after the diagnosis? So you've gone for your screening mammogram, you've had to come back and get additional imaging, and now you're sitting in your doctor's office and you get referred over to me. And what happens next? And there's this nice flow chart. I like flow charts, but you have breast cancer, and then we talk about two different parts. We talk about how can we protect your body from these cancer cells that may have escaped and are running around in your body. That's called systemic treatment, treatment for the whole body. And then local treatment is surgery with or without radiation therapy. And so two different parts. And unfortunately, you have to pick one option from column A and one option from column B, and they are not interdependent. So choosing a bigger surgery does not mean, oh, I want to avoid chemotherapy. So each one is independent, but you have to choose one from each side. How do you know who goes first? It's hard when women come in for a new breast cancer diagnosis and talk, because likely they know several women who've had breast cancer in the past, but know that each cancer is different. And then each cancer in combination with personal choice, risk factors, that gives a very specific and personalized cancer care plan. So although, your neighbor down the street or someone that you worked with may have had breast cancer, it is unlikely to be the same type, and you are unlikely to have those same personal characteristics for developing a treatment plan. And so there are many things that go into deciding whether or not a woman needs surgery first or chemotherapy. And it takes a team. Every Monday we sit here at, used to be in-person lunch, now it's via Zoom as everything else in the world. But we all sit together and we go through each patient, look at imaging, look at the pathology. Our genetic counselors are there, our oncology nurse navigators, all of these physicians here on this page who are my team members from pathology, radiation, plastics and reconstructive surgery, oncology, and the mammographers who actually diagnose the cancer. And so we discussed who needs chemotherapy and who doesn't. Remember, we talked about chemotherapy is treatment for the whole body. And chemotherapy doesn't mean the traditional IV chemotherapy where you come into the hospital. Although we still do that, we now have several options. Some hormonal treatment is just a pill that you take every day for 5 to 10 years. We have immunomodulators, and that is really targeted therapy. And the advances in all cancer treatment currently is trying to find those proteins that are on cancer cells that are different than the normal proteins on your everyday cells. And we know that prognosis depends, or is also very personalized. So it depends not only on the tumor size, whether or not it spread to the lymph nodes, but how it looks under the microscope, your age when you developed breast cancer, and then these other microscopic changes or these other proteins that are on the cancer cells. We now do specific testing on individual cancers to tell us who needs chemotherapy. So we can do a genetic analysis on your specific cancer, and it comes back with a recurrence score you can see across the bottom. And then what is your risk of having a recurrence or having that cancer grow outside of the breast in the next 10 years. If that number is high, over 15% or so, then we offer chemotherapy to help reduce that risk. And a bigger surgery is not always better. We used to think that cancer started locally and just spread continuously. So if we did a huge surgery, then we were curing cancer. And that is how we ended up with these graphic pictures here. So I used to teach a history and medicine course while I was at Texas Tech. And these are some of the first mastectomy pictures described in textbooks. But you can see this nice nun here who's looking on, no anesthetic, looking on to have her breast removed and then cauterized with this hot poker. We're gonna get better. We're gonna get better. But this was the next advancement. These are radical mastectomies that my grandmother had, where the whole breast was removed down to the ribs. Another advancement, we've got a sheet over the face, so there was a little anesthesia, or at least covering your eyes, where you weren't staring at the surgeon as the breast was being removed. And now we know that surgery is equal. So breast cancer surgery, whether you keep your breast or remove your breast, survival is the same. So we don't have to go through those horrific surgery pictures that we were just looking at to cure breast cancer. Some women have had needle localizations where we do a biopsy, put a clip in the breast from a mammogram, and then a wire helps guide the surgeon to go down and take out the area of tissue from these calcifications. Because remember, we can't feel these. These are mammogram detected breast cancers that we can't feel. So we used to have a wire show us where to go in the breast. But once again, we've made great innovation or great advances in technology so that we don't have to have those wires. Still a little barbaric to go have a wire stuck in your breast the morning of surgery and then take you over to the operating room. So now we can let go of that wire. We can use an ultrasound to help find the tumor. And we've got some other little seeds and devices. I use the Savvy Scout because it's a radioactive, it's a reflector. When I shine an infrared light on it, it actually beeps at me. And so the faster the beep, the closer we are to target the area of the breast that needs to come out, which means I don't have to take out a lot of breast tissue now around the cancer. And so this is a mammogram. Here's a little ribbon clip, which is marking the cancer that was put in at the time of biopsy. And then this little reflector is the reflector I was talking about that I shine a light on in the operating room. It's placed right next to the clip, but this can be done anytime before surgery. And then at surgery, I'm able to take out a small area of breast tissue. Remember, this thing is about 4 millimeters in size, so very small. But I'm able to focus on the ribbon that was placed, the clip, and then here, if you could look closely, are a little bit of remaining calcifications, but that was the target. And I got a normal area of breast tissue around there, so they really don't distort the size or the shape of the patient's breast. If you choose to keep your breast after cancer diagnosis and the lumpectomy or breast conservation, then we usually follow up with radiation therapy. Radiation therapy is done here on this campus. Once again, everything's done here from diagnosis through survivorship. But you come in and you lie on a table like this, and that big machine on the top rotates around so that the only area getting your full dose of radiation is the breast. So that helps keep the lung and the heart, all of those other bystanders that used to get radiated. Now we can shield those so that the only area to get the full dose of radiation is the breast. And it used to be 6 weeks of treatment, and now we can do it in 4 weeks. Each treatment's about 20 minutes a day. You come in, you go home, no side effects like nausea or vomiting. People usually come get it on their lunch break or before or after work. This is a picture of a patient that I took care of. Remember those old-fashioned radical mastectomies where the whole breast was removed down, and you can see her ribs here. We then thought we made some advances, and we did modified radical mastectomies where the muscle is still there, but still a fairly large scar and no breast. And then women came back later for delayed reconstruction. But now you can see our preoperative pictures here on the left and our postoperative pictures on the right. And one of our greatest advances is this innovation in reconstruction, where we could take your own tissue from your belly and move it up like an organ transplant, where we connect it to the vessels. So this is still a living part of your body. And I take the breast tissue out, leave all of the skin still there, and then refill it with the fat from your belly like a tummy tuck. That tissue that we normally would just throw away after a tummy tuck, we can connect it and make it living tissue so that your breast has a more natural appearance. It's warm, and we can also reconnect the nerves so that you have sensation in the breast, and they're not numb breasts anymore. So not normal sensation, but still drastic improvements in our cancer treatment. Did we have any questions about anything?
Can I be heard now? This is Portia.
Portia, did you have a question, Portia?
Yes, I do.
Okay.
My question is, at the beginning, you were talking about obesity and post-menopausal. This is a risk for breast cancer.
It is.
Is the post-menopausal, is it post-menopausal early? Is that correct?
So, so having early menopause is actually protective because you've stopped that estrogen exposure to the breast.
Okay.
But then if you gain 15 pounds or more postmenopausal, that increases your risk of developing breast cancer in the future because our fat cells produce estrogen. So it's really increasing your estrogen levels in the body.
Oh, okay. And why does early menstruation have anything to do with breast cancer? That was my other question, please.
Yeah, same thing. So it's increasing those years of estrogen exposure to the breast. And so women now, girls are starting to have their menstrual cycle at 9-10 years old. And so then if they don't have menopause till 55, you know, they've had 45 years of estrogen exposure on their breast. Plus, women are having children later or choosing not to have children. So really then there's unopposed estrogen exposure to the breast. Interestingly, when you're pregnant, it protects the breast and decreases the risk of breast cancer. So that's why breastfeeding and earlier pregnancies are reduce your risk of breast cancer. But many of us who now have careers or choose not to have kids, you know, don't do so until in your 30s. And so that's those are risk factors for developing breast cancer.
Thank you.
All right. Well, I don't think we have any more questions. So I just want to thank you, Dr. Arentz, for this important information and for the work you do in diagnosing and treating breast cancer. Of course, the community truly appreciates folks like you that are doing those important things. So thank you very much. We're going to post this on YouTube and our Facebook for future viewing. And, oh, we have a comment, but we don't have a question.
Okay.
But we do have a comment that says, thank you for all your work that you do. So there you go.
Oh, well, thank you. And thank y'all for having me.
Yeah, we appreciate it. Thank you so much and have a great day.
Okay, you too. Bye-bye.
Thanks. Bye-bye.